some background. Um, Here is Sweden, a crash course. We have roughly 10 million inhabitants. The best thing with that is that we're larger than Denmark. Denmark is, you could say, our main competitor when it comes to register-based research, and at least we have more people than they have, but we also enjoy collaborating with them. Sweden has a large proportion of immigrants. That makes register-based research sometimes tricky because it is very important we have control over the follow-up time. But if someone immigrates to the country after birth, we may not be able to have complete data on their existing comorbidities, for instance, or earlier hospitalizations. And immigrants are more likely to emigrate from Sweden, and it's important to keep track of immigrations for register-based research. We have about 10 to 15% smokers. That is important because smoking affects your comorbidity, your prognosis in several diseases. At the same time, smoking only exists in one national healthcare register, that is the medical birth register, but not in other registers. So lack of smoking data is often a weakness in Swedish register-based research. We've been to war last in 1809. I think that is important because I think being a peaceful country, most citizens in Sweden have a great trust in the government and authorities. They trust that personal data will be handled properly and not misused. And for that reason, there's a high acceptance for register-based research in Sweden among the public. I think two government agencies, or perhaps three, are important to mention. The first one is Socialstyrelsen, or the National Board of Health and Welfare. The second one is SCB, or Statistics Sweden, which is situated in Örebro, which is my hometown. That's why I wrote Forza Örebro. Well, the yellow bars here represent some important healthcare registers, like the cause of death register, medical birth register, cancer register, patient register. I could have added the prescribed drug register as well. While the blue bars represent important information that we often need in register-based research and which are handled by SCB, Statistics Sweden. Education data, migration data, death data. Education data and income data can be retrieved from the so-called LISA database, a longitudinal integrated database. I've written up a review paper about that database, but I will not go into that database during this talk. I refer to my paper. Well, the Swedish personal identity number is the basis for all linkages between registers, and very often the linkage is actually performed by a government agency which then delivers pseudonymized or anonymized data to the researcher for data management. Here's the personal identity number, and it is based on your birth date. This is 1949, August 8th, and then a birth number 007 in this case. Actually, people had expected 4 digits, I think, at the end, but the birth number just consists of 3 digits, and then the fourth one is a check digit, which is constructed based on the first 9 digits of the personal identity number. And that is to minimize the risk of mistakes, but also to eliminate cheating. War and religion. Here is some history about the different registers in Sweden, especially the total population register that keeps track of everyone. We started to keep track of our population in the 1600s and 1700s. Sweden was a warfaring country in the 1600s, and we needed soldiers. In order to recruit soldiers, we needed to keep track of our population. So the state had an interest in keeping track of our population. Then in the 1700s, the 18th century, the church wanted to collect more taxes, and they also needed to keep track of the population. So with the state and the church joining forces, I mean, it was almost impossible to work against that. So they together created a total population register, or a way to keep track of Sweden's inhabitants. In 1947, we created the personal identity number, which consisted of 9 digits by then. Then in 1967, we added the 10th digit, which is a check digit. In 2009, the responsibility for the personal identity number was transferred from the church to the National Tax Agency. The beginning and the end. The RTB registret över totalbefolkningen in Swedish, or the total population register in English, is the register that keeps track of Sweden's population. All deaths and births must be reported to this register. Immigrants planning to stay in Sweden for more than 1 year will be registered, and for other immigrants planning to stay for less than a year, for instance, exchange students or seamen or diplomats who will not be part of Sweden's population, we instead have a coordination number. I think between the year 2000, perhaps 2015 or so, about 350,000 people had been assigned a coordination number. The structure of the coordination number is very similar to that of the personal identity number. Some funny facts is that over the years, about 80,000 people have changed PINs. That is usually because they have first been assigned an incorrect date of birth. And 20,000 people have have a reused PIN. That is often because there is a lack of personal identity numbers for men born in the beginning of the 1950s, in the beginning of January or beginning of July, or women born in the 1960s, born in the beginning of January or in the beginning of July. There's this urge to include everyone in Sweden in the total population register and the national healthcare registers. We speak about having everyone on board, and that is because we feel that everyone should be part of the registers in order to develop medicine for the best of patients and for the best of society. It's also a very efficient way of using medical data in research and healthcare, and we believe it's including everyone in the healthcare register is fair because everyone is also offered treatment and help by Swedish healthcare. So this is a way of paying back or payback. In the total population register, here's an overview of that register in this paper. 100% of all births and deaths within 30 days are recorded, and 91 to 95% of all immigrations are usually recorded within 30 days. So it has, a good completeness, good coverage. Over to the patient register, and in the patient register we look for diagnosis. That is at least perhaps the most important thing in the patient register. And this is how you assign a diagnosis. This is an example of me writing up a patient chart and a summary statement after a patient being cared for between the 30th and the 31st of December 2015. And I assign a main diagnosis and I assign one or several secondary diagnoses contributing to the disease of this individual. The patient register consists of 3 different parts. We have the outpatient register, we have the inpatient register, we have the day surgery register. Inpatient means you sleep overnight at hospital. Swedish healthcare is suitable, you could say, for the patient register, but is not 100% covered by the patient register. Hospitals are covered 100%. Large hospitals, medium-sized hospitals, small hospitals. But primary care is not covered. There is an ongoing discussion and investigation whether to include primary health care in the patient register, but nothing has happened so far. We have relatively little private healthcare. I think that's important because, from my experience, private healthcare is not as good as government-funded healthcare to report diagnosis to the different registers. Important years could be 1958, when the cancer register started, 1964, when the patient register started, 1973, when the medical birth register started, and 1987, when the patient register became nationwide. I could also add 2001, when we added outpatient care to the Swedish patient register. And here is a timeline of the Swedish patient register. We can see it started in 1964. In 1987, it became complete. 1987 complete. 1997, we added day surgery to the register. In 2001, we added hospital-based outpatient care. But as mentioned, we still do not register outpatient care from GPs. And here's just a slide showing you the coverage, the proportion of the Swedish population covered by the Swedish patient register. Here you have somatic healthcare, and here you have psychiatric healthcare. What about the quality or the accuracy of the patient register? Well, I think you could simplify things and say that diagnoses which are deadly generally have a high accuracy, because physicians are unlikely to assign someone a diagnosis that this person will die from without being fairly sure. Also, diagnoses which require an intervention of some kind is generally accurate, while other diagnoses which are not deadly, not so serious, do not require an intervention, generally have a poorer accuracy, a poorer validity. Among such diagnoses could be, for instance, virosis, viral disease. Just a few examples of diagnosis and the positive predictive value. That means if you have a diagnosis of this disease, you really have the disease. In acromegaly, if you have a diagnosis, you're certain or very likely to have acromegaly in 90% of the cases. If you have two diagnoses with inflammatory bowel disease, IBD, you have the disease in 93% of the cases. If you have a diagnosis of angina pectoris, you're 95% likely to really have angina pectoris, etc. This is just a screenshot of the data delivered from the National Board of Health and Welfare for the patient register. This is what it looks like. So in the left-hand column you have LPNR, or so-called loop number. That is a serial number assigned instead of the personal identity number, because usually you get data without the personal identity number. As you can see, there are several rows for patient 32. That means that the same patient has been admitted to hospital several times, and the first time he was admitted on that is the lowest row with patient 32. He was admitted on July the 10th, discharged July the 12th, then admitted again July 22nd, discharged July 24th, admitted again 27th of November, discharged the 30th of November. And for each one of these hospital admissions, there is a main diagnosis. The HD is main diagnosis, and he first had the same diagnosis the first two times, and then had a different diagnosis the third time. So the patient register, to summarize, is very cost efficient. As a researcher, you can access data from the whole country for many years, and for a fee which is, if not nominal, quite low, usually around 150,000 Swedish crowns. It's population based, it's non-selected. It means everyone accessing public healthcare must be in the register. You cannot opt out. This means you have both rich people and poor people in the register. And data not affected by your hypothesis, because data were collected independently by a large number of physicians, often many years ago, who had no idea what you were going to study. Data are anonymized, and really they're pseudonymized, because they have some kind of identifier. That is the loop number, the LPNR number, which has replaced the personal identity number, but there can still be a key saved with a government agency, which allows for backtracking. But you as a researcher do not know the identity of the research subjects in your data file. Data have sometimes been reviewed, sometimes undergone quality controls. I'm not sure about the patient register, but for instance in the medical birth register, there is a quality control for some of the data, which means that a newborn child is only allowed to weigh, I think, between 300 grams and 6,000 grams. So a child weighing 10 kilos at birth, that birth weight is not accepted. The patient register is PIN-based, personal identity number based. So over to the medical birth register, which is another of my favorite registers. It was started in 1973. In 1982 we added smoking. 1992 we added body mass index, and it's based on several forms. I want just to make a detour and say that the fact that we have smoking and body mass index in the medical birth register makes this register pretty unique. It is the only government administered national healthcare register with these kind of data, smoking and body mass index. However, if you're looking for these data, there are other sources as well. For instance, various quality registers where they have recorded smoking, body mass index, and sometimes also blood pressure. This is one of the old paper forms that we used for collecting data for the medical birth register. These days we only use software, computer software, to enter data, which are then transferred to this register. I've noted here this is the child form. We have the diagnosis. You have to assign a diagnosis to all children being examined by a physician in the neonatal care or in the maternity wards. And the most common diagnosis is Z001A, which means this is a healthy child. This is what data look like in the medical birth register. We have variables which are included in the medical birth register, and for instance, the personal identity number, parity, body mass index, smoking, civil status, infertility, that means earlier infertility, placental weight, and some child data. This is interesting in several ways. The medical birth register is the only register where two individuals are on the same row. That is, the mother and the child are on the same row. So mothers can have several rows if they have several kids, but children only have one row each. Another thing is placental weight, which is only available, I think, up until 1982. The reason for that is that in 1982, researchers had pushed the National Board of Health and Welfare to include smoking in the register because it had become apparent that smoking was important for the prognosis of the mother and for the child. But the National Board of Health and Welfare said, okay, we're willing to add one more variable if you take out one of the existing variables. And there was a discussion what variable to take out. And the researchers agreed on placental weight, which does not exist anymore in the register. Sometimes you can combine these registers, and here's one study I had in gastroenterology, a medical journal in 2005, where we looked at the risk of very preterm birth and very low birth weight in individuals with a diagnosis of celiac disease, abbreviated CD. And we found that a mother having diagnosed celiac disease before birth was not at increased risk of very preterm birth or very low birth weight in the offspring, but a mother who had a diagnosis of celiac disease after pregnancy, suggesting that she had undiagnosed celiac disease during pregnancy, she was at increased risk of having a very preterm or a very low birth weight offspring. So what do you die from? Well, you actually die from different causes, and that brings us to the cause of death register. Here's one paper I used, the cause of death register. It was a paper in JAMA in 2009, I think, where we looked at small intestinal histopathology, that was celiac disease, and mortality risk. In 1958, we started the cancer register. The cancer register has very much the same structure as the other healthcare registers. You can see that here. In 2005, July to be exact, we started the prescribed drug register. The prescribed drug register records all drugs needing a prescription. But for instance, not all paracetamol, not all nasal drops, or not all NSAIDs, if they can be bought without prescription in a pharmacy or in a shop. So medications sold at ICA, one of the shops in Sweden, are not recorded. Neither are the drugs administered to inpatients in hospital. They're not recorded in the prescribed drug register. And the prescribed drug register does not record dietary treatment. So for me, being interested in celiac disease, that has been a problem. I've never been able to identify patients who have received a prescription for a gluten-free diet. Over to a slightly different form of national healthcare registers, which are not run by the government, but by individuals, often groups of physicians, sometimes nurses, physiotherapists, etc. People who have a strong interest in a particular disease. That is generally the case. So the first of these registers was started in the 1970s. There was the knee surgery register and the hip surgery register. The number of such quality registers have increased dramatically since the 1990s, and now we have more than 100 quality registers. So what fields are covered? You can see that to the right hand, you see the registers with the largest number of quality registers. That is cancer, motion and skeletal disorders, psychiatry, pediatrics, circulation. They have several quality registers. How can these data be used in research? Well, they can complement data from national registers. They often focus on specific mechanisms for certain diseases. So for certain diseases, you have often granular data, more details on the data. You also have data on waiting times. For instance, when was the patient referred to a specialist? When did he or she see a specialist? When did he or she undergo surgery for this disease? When did he or she meet with the physiotherapist first time after surgery, etc. Sometimes we record weight and height, as well as smoking and blood pressure. We record patient-reported experience measures, patient-reported outcome measures, and sometimes also laboratory data. So here are some things which are often recorded in patient registers, like surgery, complications, smoking, drug treatment, blood pressure, waiting times, concomitant disease. But also patient-reported outcome measures and PRAMs, like EQ5D, SF36, which is a life of quality measure, disease-specific quality of life measures, patient symptoms, patient satisfaction, pain. We speak of coverage and completeness, and very often these concepts are mixed up. Coverage is the number of units of all the units in the country taking care of a certain disease or a certain diagnosis. How many units actually report to the quality register? There might be 30 units overall taking care of a certain disease, but 20 of these report to the quality register. Then the coverage is 2/3, that is 66% or 67%. Then you have completeness. That is the number, the proportion of all patients being reported. For instance, if you have 10,000 patients with a disease, and 7,000 of these have been reported to the quality register, then you have a completeness of 70%. The coverage, the proportion of units, tend to be dependent on the number of units. If you have diseases with a small number of units taking care of all the patients, like to the left here, you tend to have at least a chance of having a higher coverage, because it's easier to tell 5 units in the country, all 5 of you must report, than here having a disease which is cared for by more than 1,100 centers. It's hard to convince all these centers you have to report, so you end up with a lower coverage. Here is coverage according to Eurostat. As you can see, older registers, which started in the 1970s, 1980s, also to some extent 1990s, they tend to have a fairly high coverage, but most of the units taking care of a certain disease are included in the registers and reported the registers. But registers which have been which started after year 2000 or even after year 2010 have often lower coverage, because there are still many units who have not come around and started to report to the quality register. RRCT is a special form of research I want to mention. Examples of this is the detox study and the taste study in Sweetheart, which is a heart quality register. These are randomized clinical trials run within a quality register. That means they're usually inexpensive but still very efficient. It makes them easy to publish, and they reflect the routine management in the clinic. So very, very important. Here is just a screenshot of the review paper I've been citing throughout now, a review about Sweden's quality register by Emilsson, my former PhD student. And that is all I wanted to say during this lecture. I wish you good luck with your course, and also want to mention that there is a Swedish language lecture about the same topic, Swedish registers. Have a really nice day. Thank you very much. Bye.